Good afternoon. Thank you all very much for attending the afternoon session. And we realize that we're competing with the beach, but we thank you for your commitment to not only each other, but the American College of Surgeons. We have two great speakers here lined up for this American College session. And I want to also particularly take a moment of personal privilege to introduce the second one first, Kyla Terhune. Kyla Terhune is one of our former residents at Vanderbilt, extraordinarily proud to be one of her attendings and now a mentee, because when she was at Vanderbilt, she was not only our program director, but was also Associate Dean for Graduate Medical Education and the DIO. We recently lost her, it is a loss, to the American College of Surgeons as she's taken her career to the next level, now educating the entire country and the world to some degree. And she's going to be joining us with Dr. Michael Sutherland, who is a regular attending person to this group, and we're very grateful to have him come. He's the Senior Vice President for Membership Services, overseeing membership, as well as many of the college's leadership groups, the ACS Health Outreach Program for Equity in Global Surgery, as well as the Military Health System and Strategic Partnership with American College. Dr. Sutherland continues his clinical practice at Northwestern Medicine, Chicago, and Northwestern Feinberg School of Medicine. So I'll turn this group, this exciting panel over to you all, and hope you stay engaged also. Thank you both.
Thanks, Sunil. It is a great honor to be here. I've been a member of this organization since I was an intern, and I think I gave my first podium presentation at this event. So it is a delight to be back here. To underscore what was just said, I'm proud to have with me and very delighted to have with me Dr. Kyla Terhune, who's joining us as the Senior Vice President for Education. And I've amended my talk to pull those educational pieces out. And we're going to let her really kind of share what's going on from the college's perspective and where we see the vision for education going in her half of the presentation. I have no disclosures, but I do want to share with you a couple of things up front. I try to front load my slides with 3 or 4 important topics that I think are the take home. So, but we can get those few slides in before everybody falls asleep and starts ignoring me and checking their phone. It'll be helpful. If nothing else, I encourage you to take a look at this document. This is available on the website from the college, and it's really a comprehensive overview of what's going on at the ACS for the year. It's a retrospective look back at last year. This is the 2024-2025 annual report. Another one will come out in December reflecting on the 2025-2026 year. And it's a great way for you to look and see what's out there. One of the things that I hear all the time in my role at the college is that I didn't know we did that. I didn't know that the college did that, or I didn't know the college had that. And this is a way that you can kind of help mitigate some of that and learn a little bit more about what's out there. All of you are probably familiar with the motto of the college is to heal all with skill and trust. We've been saying that and living that practice since 2013. Just this week, we crossed 95,000 members committed to that motto, with 144 countries representing 124 chapters around the world. We have engaged our surgeons around the world, and there is a commitment to this motto. It's evidenced in our quality programs with over 50 million patient records and over 2,200 programs that are participating in our quality programs in some form or fashion. We really try to reflect on this. We try to embrace this on an everyday basis and what we do and what we put forth as far as programming from the college, and it is the bedrock that we lean against. And it's embodied in this, which is our highest priority, surgical excellence. So if we reflect on what we're doing and we reflect on what we're doing in our clinical practices, in our education, in our quality programs, and our advocacy programs, and we identify how those reflect on surgical excellence, then we know that we're going in the right direction. And I know that resonates with everyone here in the audience, because in our own private practices and in our own day-to-day lives, that's what we aspire to, and that's what we strive for in a regular basis. So a couple of things that I think are important for you to take a note of that are new this year, that have come out, that are important new deliverables from the college that are designed to help you in your day-to-day life as you pursue surgical excellence. One is to drive some of that information, things that you can use on a day-to-day basis, to your mobile device. The college has implemented a mobile app. It's available on Android and iOS, and it is a members-only app that is available for you to download. You can see it, the mock-up on the right-hand side. There's 9 tiles there. And then just below that, there's an edit button. That edit button lets you change those 9 tiles to reflect what's important to you from the college. So if you use the surgical risk calculator, the NSQIP surgical risk calculator on a day-to-day basis, you can push that up into those 9 tiles and move something that you may not find as useful away from there. You can keep in touch with colleagues, you can review the publications of the college, and you can use this on a day-to-day basis to have quick, easy access to the features and the programs from the college that are useful in your day-to-day practice. One of the features that's also included in that is targeting the other aspect of what I wanted to focus on at the front end of my talk, which is the importance of membership. Just like every organization, the membership is the lifeblood of what we do, and our relevance is highly dependent upon that membership. While we've got 95,000 members in the American College of Surgeons, only about 30,000 of those are people that are active fellows within the United States. There's a number of residents, a number of retirees, a number of senior fellows, a number of people that are practicing in other parts of the world, and they are all committed to the same principles and are reflective of our organization, our organizational values. But we really think our core mission is providing a home for all surgeons within the United States as a primary component of our mission. In order to help our members express that, we built this into the app, and it's a great little tool. It's on the page at the very bottom. You can see where it says the membership on the far right-hand side of the bottom buttons. It pulls this menu up, and you can click on refer a colleague, and that QR code will let you be involved in a conversation that many of us have had over the years. You really ought to join the college. It's important for you. It's important for your career. It's important as a surgeon to be a member of this organization. That person and you have the conversation, you turn left, they turn right, they go on about their business, and nothing really happens. This is a way to capture that information, capture that interaction by clicking on the QR code. It brings up the screen on the left. They fill in their first name, last name, email address, phone number, the category of membership, and your name. They hit send, and then they get an email that is on the right side of the screen with instructions on exactly what to do, exactly how to do it, and a button that takes them to that link so that it makes it easy and takes the friction out of the process. It also sends a message to my staff to say, this person said they wanted to be a member. Let's follow up and make sure that that happens. So that's a real big piece of what we're doing, is focusing on membership this year. To that effect, we've heard from a number of members and a number of prospective members through a course of one-on-one conversations, some small groups discussions about our process of membership. It tends to take a long time. You fill out an application, you can wait up to 18 months before you become a fellow at Convocation. We have an interview process which is founded in some really solid principles and made a lot of sense in the past, but it's causing some people to say that's intimidating and I don't really want to do that, and I'm just going to not join the college as a result of it. So what we've done is we really thought through all this and came up with some ideas that are going to help with that process. We've moved the interview process to being a selective process. So everyone who interviews or applies to the college is not necessarily going to get an interview. If you apply from outside of the United States, you're definitely going to get an interview. But within the United States, we're going to use it predictive modeling. Who was interviewed and had problems in the past? What are the features of those applicants? And how can we predict where an interview might be helpful? We're going to centrally administer those. So instead of having 125 committees on applicants around the country, it's going to be done through a central group out of the Chicago office using volunteers from around the country. And it's going to allow us to accept applications later. We still have applications open for Convocation in September until this weekend. So if you know somebody that's not a member that wants to become one, there's still time to get in for the 2026 cycle. That shortens that time from application to fellowship, creates less anxiety for the applicants, and it takes a little bit of the burden off of our chapters for administering these interviews. We think that the chapters are super important and are a value proposition for our members. So we're going to continue to offer those names and the information, the contact information to the chapters, but in terms of an engagement opportunity rather than an interview and a high stakes engagement. So speaking of our members, we're going to shift into kind of what's going on and where we at in the college. This is a map representing all the countries that have members in the college. It is extensive and it is growing year after year. There's over 95,000 members in 127 countries. The make up of that membership is about 66,000 are fellows, and the rest are medical students, residents, and affiliates. The distribution is about 45% general surgery, 55% general surgery, 45% of the other disciplines. And you can see how that breaks down in this slide. And each year we welcome to convocation our new initiates. In 2025, there was 2,122 initiates from 93 countries. 829 of them were from outside of the United States and Canada. And it's just a delight to see the excitement that comes through when people join and walk and process as a group through the convocation process. The House of Surgery is where our slogan is, and where we see the American College of Surgeons as convening all surgical disciplines, but we do that across all career stages. We have products and programs that are designed to help medical students succeed. You've seen medical students here at this meeting presenting the novel research and important work. We have a number of opportunities for them to help them be successful. Our resident programs are extensive, and Dr. Therhune will talk about some of those. But we also have community engagement for our residents and for our young surgeons through the Resident and Associate Society and through the Young Fellows Association. It's really designed to create a forum for those individuals to represent what's important about being a resident in 2026, what's on the minds of our young surgeons who are fellows under the age of 46 in 2026, so that that can funnel up through the governors, through the regents, to the leadership of the college, so that we can take into consideration those important groups. And to encourage people to participate, we've really gone to great lengths to make this affordable. In fact, for residents, it's free. There's all the benefits of membership. Residents get to join for free as interns. If they join later in residency, there's theoretically a application fee, but if you want to sign up your entire program and they're not already all signed up, we can work with you on that. But there's just no better way to introduce people into what the college has to offer. Everything from discounted programs on benchmarking for RVUs and contract negotiation to educational programming and access to leadership opportunities. It spans the spectrum, and it has something that everybody can find engaging. This year, we introduced a new life cycle program designed for the other end of the spectrum, which is our Senior Fellow Society. And you can see there that this is a group that is designed to facilitate experiences and create a forum for our senior surgeons to continue to have relevance, to feel like they can come back together and interact with their peers and continue the fellowship with a little f that they enjoy from the American College of Surgeons each year when they gather together. We had our first webinar for this group last week, which was extremely well attended, and it focused on everything you need to know as a surgeon that's going into Medicare and approaching retirement. So how do you make these transitions to dealing with a program as a patient rather than dealing with it as a provider? For practicing surgeons, we have quite a few things that are available. These are two new products that are available for members right now, and they're designed to help you highlight the fact that you are a fellow of the American College of Surgeons. On the left-hand side of the screen, you can see the printable form. You can download this from the members the dashboard side of our website, print this out in color and put it up in your office so that people understand what it means to be a fellow of the college. On the right-hand side is a window cling that we'll be handing out at Leadership and Advocacy next week and at Clinical Congress in September. It's available if you send us an email, ms@facs.org. We'll be happy to mail you one of these. But it's something that you can use to kind of highlight the fact that you are a fellow. We've got practice management resources that are ever expanding. We've got a program with Resolve, which is our contract review program that is expanding to include access to real-time data on what's happening in surgeon reimbursement around the country. That's going to be free of charge for members. You fill out a survey, you explain where you're at and what your current situation is, and you get access to the aggregated data of everyone else who's similarly reported that. Our ACS insurance program has been around for over 50 years, and it is probably one of the most economical ways to access life insurance, disability insurance, and the like. We've got several groups that participate with us from a financial planning program, and several of those programs have actually really reached out to us after they learned about our insurance program and are now using our program as one of the options for our members to gain access to insurance, because it can beat the prices that they're seeing with many other insurance companies across the spectrum. So they're offering some great discounts for that, and it's easily accessible, and there's ever an ongoing attempt to decrease the friction associated with the concierge program that you get by calling the 1-800 number on the screen there. Will actually walk you through the process and makes it very painless. In some cases, it can be very quick. Meetings are continuing to be a big part of what we do. Next week, I mentioned earlier, the Leadership and Advocacy Summit is in Washington, D.C. It starts February 28th, goes to March 3rd, culminating on Capitol Hill with visits to talk about what's important from an advocacy standpoint. And I'm going to touch on that in just a little bit. Our Quality Safety Conference has merged with our Cancer Conference this year, and July 30th through August 2nd, that program is going to occur here in Florida, in Orlando, and we're really excited about the way that those two programs are going to come together and put all of that great content under one roof. TQIP, the Trauma Quality Improvement Program, is in Anaheim, November 13th through the 15th. And for those of you that can't make it to join us this month in Washington, but want to put it on your calendar for next year, we're going to pivot back to our regularly scheduled April timeframe. So April 10th through the 13th, the Leadership and Advocacy Summit 2027. So the last meeting that I want to highlight is still the Clinical Congress. Clinical Congress this year is in Washington, D.C., and I want to highlight two very important aspects. The first is that it is in September this year, which is the first time that is in anybody's recollection in any of the records that we can find, it's ever been in September. This is a scheduling thing related to some COVID payback that we had to do for reservations and stuff like that. So it's one of those things that just kind of happened the way it did. But if you put it on your calendar now, you won't make the mistake of thinking it's in October like it usually is. So September 26th through the 29th in Washington, D.C. The second thing is that it's still going to be that Saturday through Tuesday programming. For those of you that have been around a while, you remember that college used to start on Sunday evening with convocation and go through Wednesday or Thursday, in an effort to get the content into a compressed format so that you can be there and out of your office for the least amount of time and still enjoy all that the Congress has to offer. Convocation occurs on Saturday, so you can fly in Saturday, see your junior partner or your friends get inducted into the college at the convocation ceremony, and then move to a full day of programming on Sunday, stay a Monday for another full day of programming, and decide whether you're going to head back Monday evening and get back to work, or be able to stay with us through Tuesday for the full 3 days of programming. So I encourage you to put that on your calendar as well. The Washington Convention Center and the hotels right around there are great, and we're really excited to be back there. I talked a little bit about the life cycle programs and some of those things that we have to offer, but it also is across the spectrum of what your practice is. Everything from our surgical disciplines to general surgery, trauma. We have a number of new programs that are out there. The My ATLS app and the 11th edition of ATLS rolled out this year. We also have the second edition of the TEAM course, the Trauma Evaluation and Management course, and the Stop the Bleed program continues to be exceptionally popular. There's quite a few different iterations of this that you will see, but the Stop the Bleed by the American College of Surgeons version 3 was rolled out back in 2024 at Clinical Congress and cumulatively over 4 million people have been trained with 167 countries worldwide participating in that. So it has been exceptionally popular, and you're starting to see more and more community spaces having Stop the Bleed kits, having surgeons participating in their local communities to drive the legislation necessary to require this in schools and public places around the country. And it's just a tangible example of how we have made a difference as an organization and as a group of surgeons to provide the resources necessary to take care of people in those times of need. Our ACS cancer programs are still quite robust. The Commission on Cancer is accrediting pediatric hospitals and is also available in Canada. We're also launching rural surgery accreditation programs. The AJCC staging online continues to be a very popular resource for staging cancer and is updated on a regular basis, as well as the National Cancer Database, transforming its systems toward real-time data collection and analysis. And there's an annual report that talks about these types of changes in the cancer program in JACC. So I encourage you to take a look at that. Our quality programs have been a cornerstone of our programming at the college for the last 25 years, starting with the initiation of the NSQIP program in its current format, but dating all the way back 100 years to our cancer programs and trauma programs that started over 100 years ago. We've got multiple diamond programs related to cross-discipline, condition-specific or discipline-specific programming. And then we also have them that focus on specific populations, whether that's geriatrics or pediatrics. The diamonds have been adopted across the country, and there's data out there from survey results that were administered nationally that say that our citizens around the country put more faith in the hospital being accredited as a quality program by the American College of Surgeons than they would from U.S. News and World Report. So we think that this is, the public recognizes the importance of this. We recognize that this decreases complications, decreases adverse outcomes, and is a great place for us as surgeons to lead in the safety associated with healthcare delivery. Many hospitals have taken us up on the opportunity to place the Surgical Quality Partner logo in their hospitals, and those diamonds are showing up on the walls in the hospitals around the country. And if the hospital is verified or accredited or participating in one of our quality programs, they too can download this and put it up to signify the hospital's commitment and engagement with the quality programs. To help our hospitals even further and help you as surgeons even further, we've created searchable database online that's being accessed by lay persons and patients on a regular basis. It launched last summer, and it has been actually very popular. These quality diamonds pop up whenever you put in the geography, you put in your zip code. It shows you what hospitals are participating in the programs, which programs they're participating in an effort for patients to be able to find programs that are using those quality programs. And we're seeing patients making decisions based on that. And then these quality programs really span the spectrum from cradle to grave. I mentioned earlier, we've got the life cycle or the patient-specific groups. Pediatric surgery is one of those, and we have a couple programs in that space, as well as the geriatric surgery guidelines and the geriatric surgery verification program, which can be used in your hospital to meet the requirements for CMS for having a specific geriatric program that is necessary to maintain your highest levels of Medicare funding. So we're really trying to find ways to create programming that's augmenting what you do, driving patients to where you work and where you deliver care in order to enhance the value of the college to your practice. In order to do that, it's important for us to be able to communicate. And we've done a great job over the last few years of enhancing and revamping some of the publications and programs designed to share with you what's going on, so that hopefully we're getting fewer and fewer people saying, I didn't know that the college did that. But publications such as JAX have been retooled and revamped. You should be getting an email on a monthly basis with the table of contents. The online format's been widely accepted and is easily accessible. I'll share with you in just a second the easiest way to do that. The bulletin is similarly transitioned to that online platform, but can be a print if it's requested. But we've pivoted from kind of the old school bulletin where it was a little bit more dry and stale. There's a lot more inspiring stories and things about what's happening out there in the world, what surgeons are doing that's making a difference, and how are they engaging in their communities and in their practices in order to deliver surgical excellence. And we've been really pleased with the uptake of that. Podcasts, for those of you that like listening to things, especially while you're exercising or driving or wherever it is. The top one, The Operative Word, is based on JAX articles and it's CME eligible. The other two are more around the House of Surgery and the surgical readings, and they're really designed to kind of enhance your knowledge and awareness of what's going on, and are a little bit more topical than the first one. You should be getting a newsletter every Tuesday from the college, which is the ACS Brief, which is our newsletter that shares what's going on over the last 7 days and coming up for the college. Every other Thursday, the ACS Advocacy Brief goes out in the email. If for some reason you're not getting those emails, you may have accidentally unsubscribed, let us know. We'll be happy to get you plugged back in. It's a great resource. You can skim it in about a minute. Click in and dive in on what makes sense to you, what's interesting. And it's a great way to stay involved and stay engaged to understand what's going on. And we continue to publish videos on the website on a regular basis that are topical, timely, and designed to help enhance the experience and really dive deeper into some of the topics that are facing us as surgeons today. The dashboard is a great tool. If you log into facs.org, sign in with your username and password, this pops up. And across the top bar of the, right there in the center, it has the JAX logo and the bulletin logo and the brief. And those are the easiest ways for you to log in and access those three sets of content. So if you're ever sitting there going, I want to download something from JAX, but it says I have to log in, this is the easiest way to do it. If for some reason you're having trouble logging in, also let us know and we'll be happy to help you with that. The content in this format is curated based on your specialty. If you go in and update your information and tell us, I'm not just a general surgeon, but I'm a breast surgeon, or I'm a critical care or acute care surgeon, and you check those boxes, then your content that we deliver you on the website is going to pivot as well and track with that to the best that we can deliver. And I encourage you to go in and update your information so that we know how to get in touch with you and that we know what you're doing in your clinical practice so that we can best tailor what we have to offer so that it matches what you want to see. From an advocacy standpoint, it is the season because, as I mentioned a couple of times already, the Leadership and Advocacy Conference is coming up next week. We have a presence in Washington. We have an office in Washington. We have staff there 7 days a week working on your behalf in order to do everything that we possibly can to make sure that surgeons' voices are heard and that we mitigate any impact to us and we stand up and advocate for things that are positive for us. This is a picture of Dr. Turner, our Executive Director and CEO, which many of you know, who's was testifying in front of a Senate subcommittee on quality programs and the importance of quality programs and what we do at the college for the safety of patients and the best possible outcomes. This is a sneak peek. You can see it's the Leadership and Advocacy 26 deck. If you're going to be in Chicago or in Washington next week, I encourage you to join us because these are the topics that we're talking about. Medicare physician payment reform, the efficiency adjustment that if you haven't heard about is a 3.5% reduction in the RVU value for 7,000 plus CPT codes, including almost every single procedure code that you and I do as general surgeons. It's an abomination. It's bad science. It's poorly executed. It's everything we don't want it to be. And we have a House bill that's sponsored by lawmakers that are friendly and have relationships with us, House Resolution 7520, that's been put into place in order to delay that or repeal it. It's not going to go away any other way. And the only way we're going to get this across the finish line is for people to go to Washington, stand up, have those conversations, and say what this means to the ability to practice surgery and deliver care to their constituents, which are our patients. Inflationary updates and addressing budget neutrality are going to be talked about as well. Increasing NIH research funding, addressing workforce challenges. There's a specific act which is ensuring access to general surgery, HR 7198, which is going to be talked about, and it redefines what constitutes an underserved area, how we define workforce shortage areas, and how that impacts the augmentation of payments to physicians in those areas so that it encourages people to go and practice in those areas. And the Improving Access to Breast Cancer Screening Find It Early Act, which has got a Senate version as well as a House version, are the top 4 priorities that we're talking about next week in Washington. If you want to know more about the RVU piece, or if you can't make it to Washington, I encourage you to take a picture of the QR code. This takes you to Surgeon's Voice, which is our online platform that lets you, in 3 short clicks, you have to type your name and address, but other than that, it's literally 3 clicks. And it will send a message to your congressperson and senators in order to make them aware of this bill and the importance that this bill passing has on your ability to deliver care and your ability to be compensated for the work that you do. Work as surgeons is not getting more efficient. It is not getting shorter. It's not getting easier. And we have to be very united in our presentation of that. The stronger our voice, the better our chances are for this. And it's important that that bottom line there is that the ACS is never going to stop fighting for you. And we need your help in order to join the fight with us. I'm going to pivot for just a second here and talk about 2 programs that I think are a little bit undersold and not everybody's aware of at the college. I also live within my area, so I'm going to take the privilege of talking about things that I think we do that are really cool. ACS Hope, I talked about this in the past. It's a committee on global engagement, and it has multiple aspects to it. We have some advocacy pieces, education, but we also have a domestic and international component. This group has really done some amazing work in creating opportunities for bilateral exchange programs through the advocacy aspects, education on developing a certificate program for global surgery, which is available and started about 2 weeks ago. It's a 12-month program designed for mid-career faculty and medical students and residents even, in order to be something shorter than MPH, but really focused on learning what's involved in delivering global surgery and global healthcare and the nuances associated with that. It culminates with a certificate that they can hold out as a example of a completion of this program and expertise in this area. The domestic program is designed to really try to find ways for people to give back locally, but our international program is where we've seen some of the best success. We have 3 programs which have hubs located in Hawassa, Ethiopia, Kigali, Rwanda, and Lusaka, Zambia. These programs have been in place for up to 10 years, as the older ones, and they've really done an amazing job of coalescing the efforts of multiple academic departments across the United States, with over 25 different departments supporting these hubs by sending surgeons there to practice, to train, to educate. And what we have seen is a dramatic increase in the number of surgeons in each of these areas where they were struggling in the past. We had a conversation just yesterday with the chair of our foundation, and there's people that are interested in helping support the expansion of the operating room availability in Hawassa, Ethiopia, because we've been so successful in increasing the number of practicing surgeons there. They're outstripping the resources of the hospital. So we've added a cardiac surgeon who's born and raised there, trained there, and was completed his cardiac training with our support, who's now established a practice there and is now doing cardiac surgery in Hawassa, where in the past the patients would have to frequently leave the continent of Africa or go very far remote within Africa in order to get those services. So it's been a great success, and we've seen the same thing happen with the addition of trauma and plastic surgery programs in Kigali and in Lusaka. So it's a great program that generates increased capacity and bandwidth by using local talent and providing them with local education that enhances their ability to deliver care. Our military health systems strategic partnership with the American College of Surgeons is another program that lives within the college that not a lot of people understand or know about. And I'll share with you, this started back in 2014. It was a joint resolution between the American College of Surgeons and the Defense Health Agency. Dr. Woodward and Dr. Hoyt signed this at Clinical Congress in 2014, and it was an incredible milestone event where there's a formalized partnership that's designed to really look at how to create synergy between the civilian programs that are out there delivering healthcare in the United States on a daily basis and our military members who are tasked with having to ramp up quickly to provide care in threat environments when they arise. How do we maintain the level of readiness that our military members need in order to be ready at a moment's notice? And how do we mitigate the dips that we see in the quality or the readiness for the interwar periods? We're in an interwar period right now, and this program has done an amazing job of enhancing these military-civilian partnerships and the education and metrics associated with following it. It sponsored the development of this military readiness curriculum, the M curriculum. It's available online free of charge to anyone around the world. It's so far been translated in about 4 languages, and we have others that are rolling out. 42 interactive online modules that you can watch on your phone, just-in-time education as you're riding the elevator up. If you can't remember how to do a fasciotomy, it walks you right through it. If you can't remember what to do for somebody that has a devascularized limb, and talks you through how to put a shunt in. All of these are really incredibly well done. We keep this up to date, and the idea is that it's something that someone in an austere environment can use very easily. This was released about 4 months before the Ukraine conflict started, and the first language that it was translated into was Ukraine, and it's used extensively. If you look at the metrics from our website, it's the United States, Ukraine, and then everybody else. So it's phenomenal, and I encourage you to take a look at it, especially if you find yourself taking the sporadic trauma call and finding yourself scratching your head and want a little bit more of that just-in-time education. There's an ongoing issue that's in front of us that our military health systems partnership is addressing, and it's the specter of a next war. What does that look like, and how does that impact us in the homeland? How does that impact us as surgeons? How do we prepare for the patients that are going to be generated from a near-peer adversary war? We haven't been in one of those in a very long time. We've learned a lot from what's happening in the Ukraine, and this group has really got their hands around what's going on and how should we think about it. In conjunction with our Committee on Trauma, we've put together some slide decks for surgeons and for hospital administrators and hospital executives to really get a sense of what's going on in this space so that they can be prepared for it. And this is just a simple example of what we're talking about. And in this slide, you see on the outside of the slide, on the left-hand side, Indo-PACOM, which is India, China, Eastern Asia, and the Pacific Rim. On the right-hand side, you have Europe, Africa, the Middle East, and in the very bottom, you have South America. And this shows casualty flow back to the United States, which is how we deliver care in these environments. Some of the projections say that in a near-peer adversary conflict, we're expecting over up to 5,000 patients per week coming back to the United States. You got 5,000 beds in your hospital? Nobody does. Nobody's got 5 beds in their hospital. So how do we manage that patient flow, and how do we think about it now so that it, God willing, we're not dealing with this in any time ever, But if it does come up, trying to figure it out on the fly would be a lot more problematic than having a plan in place and understanding how to do it. So we're trying to educate people on what's going on there. And one of the things that I think is a really great factoid that you need to keep in the back of your mind is that if something like this were to happen, who's going to deliver the care? So at the beginning of World War II, there were about 1,500 physicians in the U.S. military, and 500 of those were surgeons. By 1945, there were 55,000 physicians in the military in the U.S. Today, we're in a very similar situation. We have about 500 surgeons in the U.S. military, including the Guard and the reserves. And if we have this large-scale combat operation, how are we going to flex up to a number that's closer to that 55,000? These are the kind of slides and the thought provocation that's going into this to answer questions like this. There is two ways that those people that get augmented to fill this do so. The people at the hospitals that are run by the military deploy. The people that get pulled up go to those military hospitals to backfill and deliver care there. And they also have to be able to continue to push forward. Who's going to do that? Well, many of you might not be aware, but there's a provision in the Selective Service Act that allows for the drafting of healthcare professionals, regardless of age, without having to register. So everyone that has received their training in a hospital that received federal funding, everybody that's a physician, a nurse practitioner, physical therapist, respiratory therapist, all are subject to this. And that's how this is going to probably wind up playing out, is what we're being told by the Defense Department or the War Department. So it's another thing that we're doing at the college, that we're thinking about, that we're talking about, that we're leaning into, so that we have a plan in place, so that when something like this eventually, hopefully doesn't come to pass, but if it does, we're prepared to act. There's a lot of other things going on. I'm going to stop right here just to share with you that the House of Surgery is strong. We are doing a lot of things on a very regular basis and leaning into how can we be effective in supporting you, representing you, and offering you all the tools that you will need to be successful. I encourage you to reach out to me. My email address is msutherland@facs.org. My cell phone number is there. But if you have trouble with either of those, a simple email to MS, which is member services @facs.org, will help answer any of the questions you can come up with. And if we don't know, we'll certainly get you to the right person that can. So I appreciate your time, and I'm going to turn it over to Dr. Thayer-Hune.
That was actually a great segue, because I think it moves into what we were trying to do, which is really create more of one ACS, where we have a lot of flow between member services, between education, between quality. And this is kind of coming home. You were saying that this was what you presented as a resident here. I also presented, this may have been one of my first presentations as a resident. I did a video presentation with Dr. Ronnie Clements, who rest in peace, an excellent surgeon. We did a laparoscopic reduction of internal hernia and repair. And so it's kind of nice to be able to come, because I think this is my first presentation on behalf of ACS that I'm giving. I had no slides for this. I had to create them all, so you're going to get them. But you're also, what I would call, from an educator standpoint, you are in an activated state, because I watched the room for those last few slides, and everybody was very activated, because all of a sudden you thought, oh, I might actually be called to do something in that manner. And that's good, because I'm going to talk to you about education in a different way, and introduce you a little bit to myself. That's not me, but I have no conflicts of interest. And I do want to acknowledge Dr. Sachdeva, who was in this position before me and created a lot of the programs that we currently have in place. But I also want to take this an opportunity to tell you which direction I think that we are going in the Division of Education with this. Sunil gave you a little bit of an introduction, and I'm not going to go through all of this, but I'm a general surgeon. And as all of us do in our first years of practice, we want to make sure that we are competent. We are clinically very busy. And my path originally was actually that I was going to be a basic scientist. I was not planning on this, but at the very first part, you see that education was really a pathway from the very beginning, but it was unintended for the future. I was not planning on doing that. My mother was a public school teacher in Arkansas, my father an educator. All of my studies, when I studied something that I wanted to study, it was coaching, it was education, it was psychology, but actually I was planning on STEM the entire time because I had not seen education be something that people could actually make a career out of. And being a doctor seemed to make sense. And then I fell into surgery. I was a clerkship convert, but at that point wanted to do surgical oncology. Stayed on at Vanderbilt, and it was in my third year of residency that John Tarpley, another very familiar name to this group, said, "Hey, would you ever consider doing what I'm doing?" So as a general surgeon, was chief of general surgery at the VA, followed very much in his footsteps there and in footsteps as program director. And then for the last 6 years, I was DIO at Vanderbilt. And in that situation, I actually had a wonderful opportunity from a surgical standpoint to be in touch with all of the specialties. And as the house of surgery, that is a place where there is so much we can be learning from one another. 2 weeks ago, I went to the Society of Academic Urologists and listened to what they are doing. And they are in a very unique situation that because, and I'll make a generalization here, they're a little bit more technical than in general surgery. We are also very technical, but we are also more broad-based. And therefore, their advances in some areas are places that we can learn from. And then our advances in other areas are places they can learn from. So for example, Promotion in Place, which is going to start very soon with some pilot programs in general surgery. For those of you who haven't heard of that, that's where you take a senior resident who's in their, you identify them in their 4th year, in their 5th year of chief year, you actually give them 6 months of sheltered independence as an attending. So this would be a great situation if you have someone who's identified as potentially staying on. You want to continue to mentor them in that area. General surgery is moving ahead in that area. Urology is very interested to see what's happening there. Tomorrow, I'm going to hear about telesurgery in urology, and that's something that we are all very interested in. Listening to the AI talk, it feeds into all of that. So much to do within the house of surgery with that. And I have this slide really to say that education, I fell back into that, that 3rd year of residency, but then pursued it very much so. And I'm very excited to be in this position. I'll come back to that. And this is another person who's been very influential. He unfortunately passed away in 2020, but this is Anders Ericsson. And if you've ever read the book Peak, he wrote Peak. If you haven't read the book Peak, you've heard of 10,000 Hours, popularized by Malcolm Gladwell. It was the research of Anders Ericsson. But what Gladwell did not say was that it's not 10,000 hours, it's 7,000 hours. Sometimes it's 13,000 hours. We actually do have control of how we learn. And we can reach competency more quickly, and we have to pay attention to the things around us. And it's actually about focus and feedback from experts. And so I became very interested in his work when I was in residency, because that will come into play in just a moment as I explain to you what I want you to get out of this, which is reframing education. And I'll connect this back to what Dr. Sutherland was just talking about. So reframing education. These are some slides that if any of you have heard me give grand rounds, I usually start with these because this is the way I like to talk to a surgical audience. That when you're in elementary school, high school, college, even medical school, the consumer is the learner. That is the person who's paying tuition. We are looking at their outcomes. We're looking at where they match. We're looking at what medical school they get into. We are trying to woo them with cafeteria food and dorms that make them want to come to our institution. But when we move into graduate medical education and make that shift, and it should happen sometime during medical school, the consumer is no longer the learner. The consumer is the patient. And so when Dr. Sutherland was talking to you about just-in-time learning to be able to take care of combatants when they're returning or civilians who are injured in a combatant situation, or any disaster, which we have seen situations that we would need. I mean, even COVID is a great example of this. There are times when we have to have just-in-time learning, and that is education. Education has been devalued and sort of put off to as this medical students, residents, but if you were at the AI session today at noon, or if you have lived through, which is everyone in this room, laparoscopic surgery, the advent of that, the advent of robotic surgery, education is something that continues, and if we can do it more effectively, even once we are beyond our educational institutions, we will be better at serving our patients. And then the question is, which patients are we trying to serve? Are we trying to serve the patients in front of us, or actually are we trying to serve the patients that our learners or that we are going to care for 5 years to 10 years down the road? And then, and this is a slide I just added for today because as I was thinking about this, which surgeons are we serving? And it's a combination of today's surgeons and tomorrow's surgeons. So if we were really thinking about education in the way that the college and the House of Surgery needs to think about education for all of our patients, these are the things we have to consider. And it can be very discombobulating because you think, well, that's a whole lot of people, but we have some generalizations. These are some slides I pulled from a talk coming up for surgeons as leaders. But the way people are learning is changing, and we have to pay attention to that. But the group that I have circled here are our practicing surgeons. 10 years, that's going to be this group. And everybody within that span, it spans 3 different generational cohorts there, learn differently. And so we have to pay attention to how do people learn? What are they learning? What's changing externally? What's changing internally? And this is not new. It is new to surgery perhaps, or it is maybe less familiar, but the military has known this for a long time. Businesses have known this for a long time. And so how do they measure their outcomes? They measure their outcomes by protection, and I could have put really any country there, pulled this one out, or they measure it by revenues. We measure it by patient quality, but we don't ever connect it back to education in that. So when I was in residency, I came to sort of this realization. That's when I became interested in Anders Ericsson's work. And you'll notice that in the middle, I got an MBA. Rather than a master's of education, it was actually because I wanted to learn from businesses how they were taking, see if this sounds familiar, unskilled workers and turning them into skilled workers, turning them into managers, and turning them to leaders. It is exactly what we do in healthcare. But we have tended to, I think, devalue education and say, well, this is the educator's job, or this is this job, or this is residency. And as we just showed, the prime spot for education, and you heard Dr. Sutherland use the word education, is actually with everything that we do in that sense. And so this is what, as we're looking for in the Division of Education, I would put all of these things under education. But if you look at those, you would say that was actually probably what was learned in business school. And you're exactly right. But that's what we do. That's what we do, and that's what they do. The mission is dedicated, or the mission of the college is dedicated to improving the care of surgical patients and safeguarding standards of care in an optimal and ethical practice environment with skill and trust, as we mentioned earlier. And if we look at the mission of ACS, I try to recenter on this and say, what is my job now going forward in the Division of Education? And for those of you who don't know, this is my fourth month in this position. So a lot of this is which direction are we going in this? And so I try to keep in mind some of the same slides that Dr. Sutherland said. This is a very global process, but we also need to think about the individual process. How do we educate at an individual level? So educational theory is in the background of everything. But I have found in my experience that surgeons do not respond particularly well to a long lecture about educational theory, yet you're talking about education. And so you really have to trick them. So this is my one slide about educational theory. And this is from Dr. Bill Cutrer, who developed the concept of the master adaptive learner. He has a great book on this, but I will just tell you that it's an individual who uses a metacognitive approach, and that's what I've been trying to sort of elicit here. How are we thinking about how we are thinking about how we are learning to take care of other people? To self-regulated learning. What do we need to know? When do we need to know? And are we going out and getting that? Because that's our responsibility to patients. That leads to an adaptive, we have to adapt right now, expertise and development. And I've found that when I start to put slides like this up, people start to space out a little bit because we are task focused. And you heard Dr. Sutherland say that as well. We are task focused. And so that is okay. That's actually a strength that we have as surgeons. When I became DIO, I think I could count, and for those of you who are not, DIO is the person who's responsible for all the residency and fellowship programs at an institution, and at Vanderbilt, we had 170 residency programs, 106 of those were ACGME. There were probably about 5 surgeons nationally who were DIOs. Post-COVID, I mean, I'm kind of looking at friends of mine who are in that space. I'd say there's probably 20 to 25. Almost every single previous president of the Program Director Society, Amit Joshi, Ben Jarman at Gunderson, Amit Joshi at Cooper, Ben Jarman at Gunderson, Jeremy Littman, who wasn't president but on the executive, he's at Cleveland Clinic. Jennifer Choi was president, she's at Indiana, are surgeons. Surgeons are the leaders in this space. And I think it's actually connected to COVID. because we actually, a lot of the deployment that you heard earlier, we already did at a national basis, and all of the surgeons were very active in that. Certainly a different level, but a lot of lessons we can take. So when we're talking to surgeons about education, we need it to be task-oriented, but I don't want it relegated to medical students, residents. But I also am realistic. Education sometimes happens at an individual level, but it can happen in a much stronger fashion from, for example, the lunch session today. And how many of you were in the lunch session on AI today? That was learning. People were activated, and you wouldn't have called that an education session. You would call that an AI session, right? I would call that an education session. Because if we are doing education right, it is the scaffolding behind everything that we are disseminating information. But that connection, the things that you heard, the tools that you took from that, the ideas that you got from that, the discussion about rural surgery. Sir, you brought up those questions, and I was actually thinking about the telesurgery tomorrow. I'm traveling to hear what urology is doing in that space. And that has implications for what we were doing in rural surgery and how do we get space. And I thought actually your question was in a different manner that I hadn't thought about it, but then the response was patients are already going out to AI and getting their first idea. So these are the conversations and the networking that keep us connected and lead to education. So the vision for the future of the division, the vision for the future of the division, a lot of vision in that. I was asked to talk about that in this space. And I tried to avoid for a long time reading this book that everyone kept recommending. And I'm not sure if anyone's read this, but I actually finally acquiesced and read it, and it was very, very helpful. And what I got from it at the most part was looking at absolutely taking everything with an entity and breaking it down to the smallest possible unit and considering, for example, that would be this team, this program, this individual, this direction, and saying, is this a startup? Is this a realignment? Am I strengthening? What direction do I need to go with this? And then getting a really big onion skin of everything that you're looking at. So from that, when I say what are the goals of the Division of Education for ACS, honestly, it's to support all of the other missions of ACS. And I spent some time assessing strengths, gaps, teams, and I really feel like that is done. All of these other things that I thought I was going to get done in the first year, I realize will actually be going every year as long as I'm in this position. Simply because, and I'll go back to the lunch, everything is exponentially changing, and it will continue to change in that manner. So as we were thinking about education, this will be a part of it. The current Division of Education programs that we are responsible for people who are not aware of those, plenty of programs for residents and fellows, these are all started previously, and I've had the pleasure of walking into these and seeing these. And as I examine these, we're really trying to find homes where they have the most utilization. These are all created by fellows. These are not created, I would say, even by the Division of Education. The Division of Education supports them, and I'm sure that I know that there are people in this audience who have been a part of these. These are all created by fellows, and they are very strong. And my goal right now is actually taking what we have and trying to make sure that that's as accessible as possible as we start to move in other directions. Courses for surgical residents, the previous one, I pulled this one from Dr. Sachdev, I pulled this one from Mike, and you saw this earlier, but courses for surgical residents, programs for practicing surgeons. Surgeons as leaders and surgeons as educators always has a wait list to that. So my question is, how do we pull that into other areas? This year at Clinical Congress, we'll have a shorter version of surgeons as leaders for that to try to get to more people and move through those. And I mentioned those two areas. We also, though, have patient programs for patients where we're educating patients, and these are all developed by fellows. And I bring these up because that is where our surgical expertise is in this. And also within the Division of Education, if you're not aware of these, are the accredited education institutes. And these are comprehensive simulation centers across the nation. There are 97 of them now. And one of the goals, as you'll see later, is I'd really like to focus on utilizing those, so that we're utilizing those for the entire year for practicing surgeons, as well as our earlier learners. So the Division of Education, I start by saying, who are we trying to serve from the Division of Education? And it is really all of these groups. It is the student who is thinking about going into medicine. It is the student who is going to medical school. It is the resident. It is the practicing surgeon. It is the provider. And I say provider there because I'm talking about even the providers of care who are part of our team, our healthcare team, who are providing care to the surgical patient institutions, patients and populations. And then if I look at the Division of Education and look at our teams, trying to create missions within that, where are gaps? And our gaps are currently our digital area and actually our innovation. And if we are going to continue to provide education in a way that people will receive it, we need to really strengthen in those areas. So that's coming up. How can ACS improve patient care? And it's not even specifically just ACS, but well, ACS can do it through these areas. And these are our major pillars: member services, education, and quality. However, fellow expertise is key to ACS. And so that means really having a continual supply of fellows who are coming through and able to provide that expertise by recruiting our residents, recruiting our little f fellows, our fellows who are in their surgical training, who we don't talk about as much because it gets confused with the fellows, but those who are still in training, and then the associate members, which would include those. And as I look at these, you'll see that the words change, because if we're going to improve patient care, member services is responsible really for quantity and so much more. And I would say also probably fellow expertise. Quality, we'll say that's quality. And it's really the Division of Education that is responsible for the delivery of the education in those areas. And this is where I'm trying to focus our our efforts. But one of the bigger pushes is really trying to continue to bring expertise in. So a lot of the outreach that I'm doing right now is to some of our other specialties, to our residency review committees and other areas. Quick wins, and you heard this mentioned earlier. Well, one, he mentioned that this is definitely in member services group. So why would I have this on as a quick win? And I cannot take credit for this quick win. This happened and was set into motion before I came into the position. But this is a model that I would like to see that we are providing Division of Education for everything else, which is the experts are coming from the Global Health HOPE group, but it is actually the Division of Education that is supplying expertise in the scaffolding, expertise in the delivery, expertise in how's the curriculum set up, how are the modules, do we have instructional designers who are able to do that? And that's what I'd like to do from the Division of Education. And as Dr. Sutherland mentioned earlier, it is a swath of people who are in this course, ranging from attendings and multiple specialties, truly the house of surgery, to medical students. And what you will see, and what I saw as program director and saw as DIO, is that our medical students and residents are coming in with a very different knowledge base of systems than we did when we came through. And they have things to contribute right now while they're learning about the medical side. And so this will be something where medical students will be teaching attendings at the same time attendings are teaching medical students in this. And just an example of the course design with this. So education, I would like the Division of Education to be seen as helping in the delivery and thinking about how we deliver content. Clinical Congress is obviously one of our major events, and Dr. Ken Sharp is the chair of the program committee. And we have been looking at how can we, Ken uses the phrase blow up Clinical Congress, which we would not actually want to do that, but really how do we rethink is what he means, I'm sure, rethink Clinical Congress and be disruptive, right? Disruptive in the innovative world is seen as a positive thing. How can we be disruptive about how we think about things? Well, Clinical Congress, as I learned coming into this, the program is typically set, 1 to 2 years in advance. Ken is working, Dr. Sharp's working on changing that. So there's a much shorter cycle. However, because of that, there are certain things we can change and certain things we cannot. But things that you'll see this year, we spent January asking fellows who had not come to Clinical Congress in the last 3 years why and what would bring them. What would bring them? And we have streamlined to fewer sessions. I heard someone describe the program sometimes feeling like the Cheesecake Factory menu. And you just don't even know what you should get. And then you end up ordering way too much food and you end up not eating it all, right? So it's pretty, you put all these things on your schedule and then you end up saying, okay, I'm exhausted, I'm not going to any of this. And so we want to have it streamlined. And so there are fewer sessions. We took out a lot of the redundancy. One session that I'm really excited about because we had some phenomenal nominations. Hopefully you saw that come across if it did not just go to your junk mail. But I woke up and there's actually a person in this room who was giving grand rounds at Vanderbilt. And I got out of the shower one morning and I looked and I thought, oh, they're giving grand rounds. I want to go to that. And I thought, How do we get that at Clinical Congress so that you get the email and you say, oh, this person's speaking, I want to go to that. And so we actually realize, if you think about the speakers that you've heard and you've walked out and said, wow, everyone should hear that. And then what an honor for a fellow who is giving a grand rounds for someone to come and say, look, give it at a national stage. It's like asking them, give it as a TED Talk, give it to all of give it to all of Clinical Congress. And so we solicited nominations and we got 24 really phenomenal nominations. We're in the process of whittling that down to 2 to 3 who will be essentially unopposed plenary speakers during Clinical Congress. We also have some very exciting plenary speakers, and those will come out as advertisements throughout the year, so you'll be able to see. And we want people to look at that and say, I want to go hear this person talk. And then Clinical Congress, Mike, I'm going to get you to change your phraseology. You said you might leave Monday night. We want programming to be so good that you stay until Tuesday, but we're going to stop it at 2:15. That gives everybody plenty of time to get home. One of the sessions that we will have Monday and Tuesday, working with Genevieve Meltmo, is on AI, clinical informatics, because that is what we were talking about. And then we also are edging it in. So as I said, the program is already solidified, but we want to make sure that we have things that are up to date and being created now for Clinical Congress that is just in a few months. So I can't even tell you all the topics because we want those topics to be relevant and hot now. And so please consider this year giving it a good start. And we're trying to make sure that when people are asking us, hey, can I move off of Tuesday because no one's there? We're saying no. We actually want people to say, I want to go Tuesday. So I want to go Sunday through Tuesday. And when you have a really good program, it's our job to provide value, and we want to do that. And then having some of these larger sessions, which you'll hear about later, be unopposed. Other things that are in progress, as I mentioned earlier, I am really trying to reach out to specialty societies. The Division of Member Services has given me a lot of data. We have a lot of data on Clinical Congress as to who comes, why do they come, what do they go to, and how do we really create something? And, as I say to the division right now, we have to take everything and put it out on the table. I mean, and you see, if I am just speaking transparently, you see that in a meeting like this, right? I would love to think that everybody who registered for this meeting wanted to come and hear us talk, but clearly that did not happen, right? So, and we got to work on a better title next year. ACS updates is going to have to be, yeah, or less beach. Yeah, we got to move it somewhere and bring in the rain. But we want people to come down. So the outreach is really important, but I would ask you all for your engagement there. I talked about clinical informatics. We're working on that. And the theme that President Sadawi put in place is the House of Surgery, a home for all surgeons. So how do we actually create that? That's where we should be. There is so much I have learned from other specialties. And we have so much to share. And the ACS is the only place. That is what is unique. That is our value. That is the only place where we all come together. So how do we do that? And then skill sessions, there will be AI skill sessions this year. So imagine what you heard at lunch, but you actually will have your laptop in front of you. You are working with it, playing. We have some very dynamic chairs for that course. I'm very excited about that. That will be one of the didactics. We also have dropped we changed the pricing of the didactics with that in the skill sessions. And then reskilling for readiness is very similar to thinking about how do we prepare ourselves. If I'm an endocrine surgeon, yet I did trauma as a general surgery residency, if I'm going to be called upon it, how do I ready myself for this? So working with trauma, working with others to create that and bring people together in Clinical Congress for aspects of that. But we don't want to stop at 2026. Those are just the things that we could change because we have the opportunity to change. This summer, I'll be reaching out to many of you all. Please volunteer what you would like to see, how you would like that change, keeping in mind the House of Surgery and how can we make that valuable. So we'll be asking a lot of questions and trying to revamp. And that year, it used to be 2030 up there, and then I think I changed it to 2028. I'm feeling more and more confident about saying, let's do this in 2027. And I really want us to ask hard questions about how we convene, and not just at Clinical Congress, but throughout the entire year. I didn't touch on it too much, but the innovation and the AEIs, we can have elements of Clinical Congress at what we offer regionally. I was at the ACGME meeting in San Diego for the last few days, and I went and toured the simulation center at UCSD, and it is phenomenal. And so when we are in San Diego for Clinical Congress 2027, we likely will have courses there. And they have an entire room that is devoted to plastics and skull-based surgery and otolaryngology. And those are groups that we want to be a part of this because there are things that we can learn from those spaces as well. How do we create more connection? And how do we act on our responsibility? You heard at the end a little bit of what our responsibility is, which is creating a network of capable people who can step up if we need to with that. So those are just some examples of that, thinking about the individual and thinking about the connections. How can you get involved? These are our existing committees. These will change over time, but there are places within member services to get involved, places within the Division of Education. Just reach out. We will find places, but I would love to create just a little bit more of an understanding of what our future is together with that. And the most important part of how you can get involved is by modeling. And so I'm finishing with the same slide that Mike had in his, which is bringing, and we kind of need to add that, residents and fellows as free ACS and training. Must be on automatic, isn't it? I stole that from you, and it is as free ACS members. And this, I'm trying to get to all the surgical DIOs because this can be an enrollment on onboarding. This can be enrollment directly from, there is no side effect to our orthopedic residents, our neurosurgery residents, our otolaryngology residents, all of our general surgery residents being members of ACS. And I get the chance to sit on all the residency review committees to which ACS nominates. And so I went to, and every time I talk to Kathleen and Mike Shop about how many fellows do we have in this specialty and what are their divisions. And one of the surgical specialties recently, when I looked at their numbers, 4,000 fellows, which actually for the number in that specialty was quite high. However, 2,000 of those were senior or retired. And then with that, in their residencies, I think it was about 300. But we have plenty of programming and things that we can do. And the last thing I say is what I'm trying to do right now is find gaps. So there's a group, so if any of you are in education, interns, we're going to have actually an early boot camp in early June, trying to capture people who are either IMGs coming into the country who want a little bit of boost in technical skills and understanding culture and understanding different areas, or preliminary surgery residents who didn't know they were going to be doing a surgery internship year and would like a little bit more training right before they go off and meet their resident cohort, or anyone who just wants to come and learn from really spectacular educators like Jeremy Littman and Roy Fidiakorn, and others who are going to be faculty for that. So I'm trying to find gaps of where are things that we are not able to offer in different areas that we as ACS can offer. So happy to receive any questions. We're starting to receive any emails, and if anyone is interested in any of the things that we're doing, I'd appreciate that. So thank you.
So I do want to blow up Clinical Congress. There's the old saying, you go to one grand rounds, you've seen one grand rounds. You go to one Clinical Congress, well, you've seen all of them. They have not changed in over 3 decades, other than tiddling with the days of the week and shortening it. We have more material presented in 2.5 days than we did when it was a 5-day meeting years ago. So we've gotten bloated, we've gotten stale, and I can't tell you how excited I was when Dr. Terhune accepted this position as the SVP of Education. We have a new sheriff in town. We can change things, and I really want to hear from everybody about how should we change. Might even work for this meeting, seeing that the attendance here is a little on the light side. But I really think she is totally dedicated to making the most exciting, engaging, interactive Clinical Congress we can have. My only correction would be is we don't want people going home at 2:15. That's when the annual business meeting of the fellows occurs. If you want to hear who the new officers are, exciting news in leadership, stay for the business meeting on Tuesday afternoon. So you were a little unhappy that Mike wanted to send people home on Monday night. I don't want you to send people home at 2:15 on Tuesday.
I will have that caveat.
So, yeah, don't forget that part.
And to this point, when we ask fellows, I think all of us would say one of the reasons we go to Clinical Congress is to see our peers, right? And in that, that's okay with me too, because that is education. And so if in seeing our peers, we are also having the conversations about what's going on in your shop, what's going on here, what is different. And I'd like to expand that to, that is the place that we also are learning from our peers in other specialties. How can this be applied here? And you've done actually a lot with the resident lounge this year and in other spaces.
Yeah, so we're trying to create spaces where that engagement can happen and where it can happen naturally. I mean, many of us go to Clinical Congress and go to our chapter or our alma mater's reception for that very purpose of interacting with people, seeing how people are doing and that sort of thing. So if we can create those spaces in a more regular environment that you don't feel like you have to have a ticket to get into, then we've been very successful with that. Dr. Britt.
Thank you both for coming. It's so fun to see my friends leading the college. Rebecca Britt, Norfolk, Virginia. So many years ago, I was the CFAS rep to the AAMC for our institution, and I would go to the AAMC meeting every year, and they would have a speaker that would bring in 5,000 people, and there were lights and there was bling, and it was, one of the years it was Atul Gawande, for example. And I've not ever seen the college at the Clinical Congress do something like that, where literally people were like stampeding through the doors to get there. So I love your idea of bringing in some, different style of education, and I look forward to that. But I can tell you, as somebody who's attended a meeting that does that, it really was so dynamic and really got the energy up. So I highly look forward to that.
Yeah, that is something. So for 2026, I'll just say, first of all, for Beyond, we are definitely looking at that. And we want to have people who are outside of surgery, because where we learn innovative practices is sometimes not from within, right? It's from outside and things that are adjacent. And so Atul Gawande, of course, is one of us, but from other areas, from industry, from leadership. So certainly that is on the table. In 2026, just by chance, some of our named lectures I think people will be very excited when they see those announced and when they see advertisements for those. And then there's some other people that we're trying to pull in. But the grand rounds was exactly what could we do in 2026 that would be a bridge between that. But also, I really want the best of grand rounds to be a real honor that when you're sitting at your institution and you hear someone give something, because we're going to notify everybody who was nominated to say your peers thought that your grand rounds was worthy of being on a national stage. And so seeing that as a place to come forward. So in the future, I hope that we've got those plenary speakers. We also have our named lectures, which that's the part that this year I think we're going to have we do have some very excited named lectures, which will be announced. And then we also will have the best of grand rounds and have more of that community. I think we'll see. Well, I won't go into everything.
Your point's well taken. It's not just the content, it's also the dynamic in which you present the content. And if we can create an unopposed environment where there's a hype and there's an energy associated with it, there's things that we can do on that. And we're not just blowing up Clinical Congress. We're kind of I tell my team on a regular basis, we have to think differently. We have to think differently about every aspect of what we do, because the member that we're servicing is evolving. And if we don't evolve with that member, then we're going to be irrelevant. So it's a huge, huge undertaking, but we're taking it very seriously. Yes, sir.
Eugene Chavley in Campbellsville, Kentucky. Is the college advocating in addition to reduction in RV use, but also further reduction in Medicaid?
So the college, the RVU piece crosses everything. We're talking about the enhancing the reimbursement associated with Medicare, and that's governed at the federal level. The Medicaid piece is a little bit more complex and nuanced because there's a lot of moving parts with that, and it's not specifically on the agenda for the 4 asks this year, but we're addressing it as it's relevant to CMS. Once those dollars flow from the federal government to the state, how the state implements those is very broad.
One other question. Has there been any discussion with global surgery partnering with very successful groups like, for example, PAX in Africa?
So the way ACS Hope started was Operation Giving Back. And this started about 20 years ago. And those alignment and the way Operation Giving Back worked was you would volunteer and we'd help point you to existing programs that were out there that were doing that type of work. Those relationships still exist, and we have a large number of people that come to us and say, I want to do this, but I'm not set up to do what you're doing in these hubs. And we plug them in with Doctors Without Borders, with Mercy Ships, with other programs like that that are well established and can accommodate a single surgeon or a single surgery team that wants to come and augment in a space.
It's nice seeing you all. You're both here and welcome. Don Nakayama from Columbus, Georgia. You know, the thing, my involvement in the college always struck me was we're not really competing with other professional societies. We're competing with YouTube. We're competing with whatever my medical students are looking at on their tablets. And they're just imbibing education in a different way. They're imbibing, their professional associations are just plain different. And are we holding on to a system that is rapidly fading? Are we kind of like the Washington Post? Are we like the Big Four network news? Is it something that's gradually growing out of favor, and professional societies really are kind of fading and we're just holding on?
So first, I would say in terms of the digital format, I think you will see changes in the college in the digital format within the next year. And some of that is to make sure that what we have is accessible, but the format that the college or the content that the college has is still unsurpassed in that. Your question is great. How do we provide value as a society, and is a society valuable to people? And in terms of what AI can replace and what AI cannot replace, the one thing that we are hearing more and more is that the actual human connection cannot be replaced by AI, even if the information is just as good. And for these generations that are coming forward, when you ask them how they like to be, it's actually the relationship that is incredibly important to them, the belonging. That is why you're seeing unionization pop up, the sense of belonging. And so if you can actually create a sense of belonging that has value to it, that can still be of value. And we're seeing that in actually the actions that they're taking and the votes that they're taking. But I think, you know, you have to ask those questions, right? And the bigger question, the second question would be, well, does the college just completely need to change formats, and what would that be? I think there's still going to be value to that belonging based on people coming through. And I think that member services, you probably have more to say about that.
Yeah, so I think it's a great question. It goes back to what I just said. We have to think differently. We have to behave differently as an organization. Our incoming members are demanding a different level of engagement, a different type of engagement, and they value that belonging and the community more so than what we saw from members in the past. I mean, when many of us joined organizations, it was because somebody said, go do this and it'll be good for you. And that was all it took. The value proposition for our incoming members is much more nuanced, and it has to be tailored to match what they're looking to get out of it. We have to create these environments where they have the ability to network. We have to create areas for them to share experiences and relate with one another while deriving educational or some other tangible benefit. And that tangible benefit for every single person is going to be different. So we have to have a wide spectrum of them that are easily identifiable and approachable. So when we say is the college going to exist the way it is today? Is Southeastern Surgical going to exist the way it is today in 5 years? I sure hope not, because that puts us at risk for what you're asking is, are we going to become irrelevant? We have to adapt. We have to evolve. We have to change what we're doing to meet the consumer, in this case, our members, where they are, because the number of dollars for membership is shrinking. The impetus to join is shrinking, and we have to reinforce the value proposition every single opportunity that is available to us in order for people to natively just say, of course, I'm going to do that. It's not a question. Yes, sir.
Jason Clark, I'm at HCA facility in Charleston, South Carolina. My question is in relation to the Congress, and forgive my ignorance because I'm one of those people who rarely goes unless I have to.
We needed you in the
And-
focus group.
So I'm also a hand surgeon and a trauma surgeon, so I go to the hand meetings, which are quite entertaining, all stuff going on. But the biggest thing that they do have is like lots of hands-on stuff that they're actually going into a room, working on new products, anatomy, whatever it is. Does the Congress offer anything similar?
So there are two things that come to mind when you mention that. One is the hands-on skills courses. So all of Saturday, Sunday, we have skills courses, and those are in various areas. And that was what I was mentioning earlier. The cost to those, if we can partner with our AEIs or our groups, for example, in San Diego, and we have co-sponsorship of those, then we're able to offer even more of those that would be in that area. And actually, if you want to, I had a second part, but I'm blanking on what it was. Did you have anything to respond?
No, I think it's important that we have those types of experiential courses available. And I think one of the things that the college does is that it brings together the opportunity to have plastic surgery, orthopedic surgery, general surgery, and everybody else that does hand to come together in one place and talk about that. Or in circumstances where there's other overlaps, the pelvis, for example, in trauma. We wind up having panels with urology and gynecology and general surgery, and we bring in expertise from outside like interventional radiology. In order for us to leverage what we have as the House of Surgery, using our convening authority to bring together multiple disciplines into one location gives us some leverage to do things that other places struggle with. And to your point, hand surgery is a great example of that.
And the second part I remember was not everything has to be CME related. And so one of the things that a lot of these organizations will do is that they will partner with industry. So for example, in the exhibit hall, and having courses that are there, or bringing additional exhibits in where people are actually showing and having hands-on things in that area. So in 2027, not that we want to steer everything towards that direction, but that is part of seeing what is innovatively happening, is actually having those spaces effectively utilized as well. So that would be the second part where I think we'll see more.
So this has been exciting. We've got questions all the way to the last few minutes. So maybe I'll give the last question. Could you give us an update on the Academy as a new member? I didn't see that in your slide, Kyla, the Academy of Master Surgeon Educators.
Sure. So the Academy is actually, Dr. Sachdeva has continued his work with the Academy through September of this year. And what we will need to do at that point is really determine how that's sort of incorporated back into it's in the Division of Education right now, but it's not on my slides because I'm not completely responsible for that right now. However, the Academy is still strong. The Academy has incredible thought leaders, has influence, and a lot of the topics that the Academy has taken on, you'll see in some coming white papers, which with your involvement, I'm sure you've seen some of those as well. But it's a very influential group. And for those who are not familiar, the Academy of Master Surgical Educators is a group of not just those who education has been their career, but chairs and presidents of groups and very influential individuals who have supported education from this area and have seen it through different lenses. So when we talk about really the collaborative nature of that, it's still going strong, and we'll be advising. And the way I really see it is that would be a thought group advising the things that we do within the college.
Thank you all for the opportunity to present today. We will be around if you have any questions. This has been a great honor for us, and really enjoyed the questions and answers afterwards. I think that the interest here is great. And if we can do something to support you in your practice or in your career, let us know.